So we're going to be doing a C7T1 upper thoracic mobilization today. Basically what that is for is it's to restore the thoracic extension, which is essential for proper scapulothoracic rhythm when reaching overhead, which is essential for functioning there without a coordinate sign of a painful arc or limitations when reaching overhead in that range. Basically, the reasoning for this is that when we were doing our evaluation, we saw limitations in the segmental level of C7T1 in thoracic extension. So we just need to do this mobilization to regain that mobility so then we can then reduce that concordant sign and then retest that and then have an intervention to reinforce and reload. So basically what we would do for that is that we would use a controlled movement pattern. So that would be neuromuscular re-ed with a cat-cow exercise to individually target each segmental level. So we would have the person go through that very slowly, about 3 to 4 seconds per movement. And then we'd have them probably do that 10 times, take a rest, and then continue for maybe 3 more times just to kind of reinforce that segmental movement at each level and that coordination pattern training that we've been working on. Found some limitations in your thoracic mobility, so basically just your upper back motion, and that's kind of limiting us in our overhead reaching, and her mobility is leading to like a decrease in her scapulofemoral rhythm, so we're just going to try to regain that with the mobilization. So basically what we're going to do is, since we're limited in that extension, we're going to try to get it back with this little movement between the spinal segments. So basically we're going to come in behind here. It's going to be like right around this area. We're going to find C7 and T1. So C7, if you like bend your head down and then back up, we're right on C7 right there. So it's the one that doesn't move, and then we'll just go right below it for T1. So basically what happens, what we're going to do with the wedge is your vertebrae kind of sit on top of each other. So then when we load one, it'll kind of have a little bit of a gapping, so it'll help you with that extension. So if you want to lay down, I'll have you lay down facing that way. And then I chose this intervention because I figured if it would work, I'm just going to slide this under your arm. This would work well if someone was like post-surgical or a little bit bigger or just like general, it would just work a little bit better for body mechanics and things like that. So I'm going to have you, if you can, bring this hand up and cover up the shoulder there, and then this hand's going to come across. Do that just for another point of contact between the patient and the therapist, and then also if she had like a surgery or something like that, it would protect the surgical site. And then I'm going to come in, so when I do the mobile, I'm going to come around and kind of wrap my arm around you. Is that okay? Yep. If you feel uncomfortable at any moment, just let me know. So we're going to come in here. My head seems like it's in good alignment. And come here. Can you bend your head forward for me? Good. And then back up. Good. So we're right on C7 right there. We didn't move at all when she did that. And then we'll come right below that, T1. And then we're going to put the block on, or the wedge on the transverse process of that. And then we're going to apply a anterior and superior glide there. Over here. And then we're going to kind of wrap around. And then we're going to take up the slack, find our 1, find our 2, right about there is her end feel. We did our assessment so we know that she could go up to that point before this, but there's our assessment there, and then from there we can move straight into our mobilization, which for this, since she has no pain, you had no pain with that assessment just there. Nope. So perfect, so we're good with no pain, so we can go straight up to like a grade 3, grade 4. For the purpose of this, we'll do grade 3. We'll do it at 1 oscillation per second. We'll come in here. Again, take up the slack. 1. And then we'll just kind of bounce off of that. And then we'll do that for about a minute. For the second time, I won't do the whole thing. But good. And then mobilization with movement. Basically what that one is doing is it's an accessory joint mobilization with active movement of the arm. So we'll be joint mobbing in the posterior lateral direction while the patient goes through that overhead reaching with their accessory joint movement. So basically the point of this and the purpose is to reseat the humeral head in a posterior inferior lateral kind of direction when they're reaching overhead, to hopefully reduce their concordant sign and their painful arc of motion, which is the 90 to 120 degrees. We'll use this joint mob to refacilitate that scapulohumeral rhythm as well. An indication that we would use this is, again, if they had like a painful arc or we saw some scapular dyskinesis when they were performing their overhead reaching. So when they would go through this movement, I would have them go up and down 6 to 10 times. So for the sake of prescription, I'd probably tell them to do it like 8 times. And let them know that it may be a little bit more painful when they first start just because of that range, but not to go into the pain and to come back down if they do feel the pain, and it should go away kind of towards the end. And then my retest would be, again, just redoing that overhead reach range of motion, see if there's improvements in scapulohumeral rhythm, as well as a decrease in their concordant sign of their painful arc. So that would be a positive pill principle if we saw reduction in their symptom as well. So for an intervention or an exercise, I would have them do wall slides. So I'd have them find a wall, slide up, come back down, nice, slow and controlled. If they could, I would have them go up, do a serratus lift off, and then come back down. So this would be working on their lower traps and serratus anterior muscle activation with overhead movements. So basically what that would do is it would help facilitate that upward rotation and posterior tilt of the scapula, which is essential for scapulothoracic rhythm and their scapulohumeral rhythm. So basically it would help facilitate that, and it would work on their functional movement with overhead reaching, which is exactly what the mobilization was working on as well. And that would be a neuro re-ed because we're trying to like retrain that motion and we're focusing more on the movement pattern of the scapula and trying to keep the scapula and the humerus in that rhythm. In our eval, we had some pain when we were reaching over our head kind of in this motion. So today we're just going to do a little mobilization to help with that. So basically what's going to happen is I'm going to be trying to move your arm, your upper arm, kind of in like a posterior lateral direction. So it's basically just going to feel like kind of a bit of pressure there. And then I'm going to bring you through that uppercut motion. That was a little bit painful before. It might be a little bit painful in the first 1 or 2, but it should get better as it goes. If you get too uncomfortable at any time, just let me know, okay, and we can stop. Right. So we're going to start here with seating her hand right there. I'm going to palpate for her clavicle just to make sure that I'm not on there. And then I'm just going to kind of wrap around here. And then I'm going to come around the back, relax your arm. I'm going to find her scapula there, so I'm right on, my web space is right on her inferior angle, and then we're going to kind of go up through the motion, good, and then come all the way back down, good, and then we're trying to maintain that glide the whole time. One more, good, next one, good, okay, relax. Okay, so that was the test. We tried to make sure that we were maintaining the posterior lateral glide throughout the movement as we went up and down, but still letting her get through that full range, full non-painful range. So the taping technique was used because in our evaluation, we noticed that they had limitations or pain with overhead reaching or cross-body reaching, which improved with a manual correction to posteriorly shift the humerus into more neutral position. So we decided to use taping to manually correct that alignment of the shoulder and the humerus into a more neutral position, and allowing that a mechanical and proprioceptive cue by using the tape. So basically what I would do for that, for my retest would be to put the tape, so originally we would assess, we would move it, and we would have them do those motions to see if the pain improved. If it did, we would add the tape, then retest the same motions to see if the pain was still improved or if it went back to what it did before we did the correction, if it was still painful. So we would just reassess for that. Again, that painful arc when reaching overhead, 90 to 120, or again, a cross-body movement that improved when we seated it more posteriorly. So we retest that, and then I would have them do probably an isometric external rotation. So I put a towel, you can't see, I would put a towel in between their arm, and then I would have them either stand up against a wall or have the therapist do it. If that was at home, we want it to be applicable so they could do it at home for their home exercise program. So I'd probably have a towel in between here, have them stand up against the wall, and then have that wall just apply that pressure and just have them push into the wall. And basically what that'll do is it'll help seat the humeral head a little bit more into that external rotation. Well, it'll be working the external rotation, and it'll help it to seat more posteriorly. So then the shoulder gets used to kind of that kind of movement, and that also reinforces that posterior cuff activation to maintain that alignment of the humerus posteriorly. So it'll retrain kind of like the nervous system to maintain that position by itself, so that when we remove the tape, hopefully the brain remembers that movement and it knows that the humerus should be seated a little bit more posteriorly, and kind of pulls it back into that motion where it's used to being from the tape. So that's why it would be neuro re-ed for that one. We had some limitations with reaching overhead and across body. Found this a little bit more painful, but when we kind of pulled the shoulder back and like manually moved the humerus, which is like your upper arm bone, then we found some relief with that. So we're gonna do a taping technique today. Do you have any allergies to adhesives or any sort of tape that you know of? Nope. Perfect. If this does cause any like burning, itching, any rash, like when you go home, just take it off and let us know. Okay. So we're gonna start with this tape. Basically we're gonna go from this side of your and around your arm to the back. So yeah, we're gonna find the coracoid. So there's right there. And then we're gonna try to have their arm in neutral, so bring your arm back just a tiny bit. There you go. And then good. And then we're going to come around into the spine of the scap. And then we're just going to lay that piece down real quick. So what this is doing, this particular piece, isn't doing the seating the humeral head posteriorly, but our next piece of tape will be what we'll consider our liquid tape for the sake of the skills check. And that will be the one that we applied the stretch to, that will help seat the humerus a little, or the humeral head a little bit more posteriorly. So we're gonna make sure that we come off and I move the humeral head. There's some creeping in there. So we're gonna seat that a little bit more posteriorly, and then this will reduce the mechanical stress on the anterior portion of the capsule, and just overall help with motion. So we're gonna go a little bit shorter than our tape, our coverall tape, since we have a little bit more stretch on this one. So this one's gonna come in, gonna go straight over the other tape, and then we're gonna apply a little bit more force here. We're gonna seat this a little bit more posteriorly. We're gonna pull, stretch on there, and end it right there. Good. And then we'll make sure that everything's adhered there. And yeah. And then for our, we would just retest and see if she had limitations, if she had decreased pain with those overhead reaching and across the body reaching. And yeah, so if you go home, you can keep this on for like 24 to 48 hours just to see how it feels. If it starts to really, really hurt, if you get like a rash, itchy, redness, anything like that, take it right off and just let us know. And yeah.